I'm from this famous hospital in Munich, which was shared 100 years ago by Kraepelin, and also Alzheimer worked with Kraepelin. So we have a strong neurobiological background there, and also my main research in this field of neurobiology and neuropsychopharmacology. But today I speak about something which is, of course, closely related to psychopharmacological treatment, and we probably do not think so much about this when we administer or prescribe drugs to our patients. We believe that they will take these drugs, but of course they often do not, which we call non-compliance or non-adherence, and this is really a very limiting factor in drug treatment of our patients. I'm not thinking only about schizophrenia. They are mostly accused to be non-compliant, but also other patients, like the depressed patients, are non-compliant. So I think it is an important topic, both in the interface between, let me say, psychopharmacological treatment on the one side and psychosocial caring and psychosocial treatment for our patient. So because this topic is not directly drug-related, I skipped my disclosure charts, and I start immediately with one of the core topics of my presentations, the topic of non-compliance and non-adherence. And there are several words: compliance, adherence, concordance. I was always confused about these terms. I know that it's now politically correct to speak about adherence or even concordance, and compliance seems somewhat outdated. But if you look into the semantics, I think it's not so clear what is the difference of these three topics. I tried to define it, but I'm not sure whether this is really correct. But I will use these terms, especially compliance and adherence, synonymously to not confuse you. But I would like to focus a bit on this term concordance, because it bridges really to what I want to present you today, the concept of shared decision-making at the end of my presentation. And I think concordance means that doctors and patients share, at least finally, the same position, so that they can develop really a partnership between the doctor and patient. And this is somewhat totally different to what, for example, I started when I was a young doctor in psychiatry more than 40 years ago. So we learned that you have to inform the patient what he has to do, that you have to prescribe the right drug for him. He has to understand that your decision is right. So this, let me say, very paternalistic approach was, let me say, at that time, very much in fashion. And nowadays, we understood that patients do not like this, and that patient also might become too passive in her role and too negative about their own role and understanding about the disease, the necessary treatments, and so on. And therefore, the more idealistic direction in which we go now is this shared decision-making process that gives an equivalent position to the patient views and the doctor's views, and the doctor has to respect the patient views, which are sometimes totally in opposition to the views of the doctors. So I think the problem and the size of the problem is quite well known. About 50 or even 70% of patients with schizophrenia are non-compliant during the long-term course, even if we count only 6 months or 12 months. And of course, this is something which has deep impact into the outcome of treatment. Sometimes we blame only the schizophrenic patients or patients who have the diagnosis of schizophrenia, to be more correct in our wording. But we know that also the patients with depression have a very high rate of non-compliance. They like to come to the doctor, they like to speak to you and me, and when you ask them, what about your intake of your wonderful antidepressants? Well, of course, I take them sometimes. If you ask a bit more in detail, you find out that they are extremely uncompliant. So, and then you ask, why you come to me? You're a nice guy, you're a nice doctor, I like to talk to you, but I don't like your medication. So we have to overcome this non-adherence and also partial adherence, which is somewhat more often the case than the non-adherence, is a big problem in drug treatment. It leads finally to increase of symptoms, to relapses, rehospitalization, and so on. And this is a downward spiral which finally ends also on the side of the patients into loss of confidence and demoralization. So also for himself, it's finally not a good event. We know very well that patients who have a relapse do not respond as well anymore as at the first episode. These are data from our own study in Munich, where we demonstrated this, that patients with multiple episodes do not respond as good to the treatment with antipsychotics than patients with first episode. So these first patients with schizophrenia. And there are other data like this, and we say sometimes that it needs, besides the rehospitalization, often 1 year for the patient to really recover from the relapse, and therefore we have to try our best to avoid these relapses. Already minimal gaps in the days where the patient takes this medication can lead to an increase of symptoms or even to rehospitalization, as this was shown here in this slide by Weiden. And there are also other negative consequences of non-adherence. I take here again schizophrenia as an example, but it's similar also in depression, bipolar disorder, and other disorders. So for example, the cost of relapse is much greater than just the cost of hospitalization. We have to take this into consideration in the time when there are so much problems that states can pay the health system, and that there are tendencies to cut the cost in the health system. So relapse is much greater, the cost of relapse is much greater than cost of the hospitalization. Patients have to undergo a long time of unemployment, and so on and so on. So really, it's important that we try to increase the adherence and to avoid in the best way the relapses of the disorder. How to measure non-adherence? It's not so easy to measure adherence. Of course, we trust primarily our patients, and if they say that they take the medication, we like to believe them. But you know, I become a bit cautious in my expression. We like to believe them, but we also know that they probably do not take their medication. And it's not so easy to confront them with this, because this would induce shame and bad feelings in the patient, and finally it would, let me say, break the positive doctor patient interaction. So it's not so easy, but we have to ask, and you should ask the patient. Asking is not enough, so pill counts are better, and there are other ways to even get a better indication for compliance or non-compliance. For example, drug monitoring is of course the best way, but is costly, and under many situations in the healthcare system you cannot really pay for this issue. And then there are other systems, the medication event monitoring system, so you have this pill box which gives an electronic signal for recording. This is also a way to count for this. What is very, very important, and I would like to stress again, it's not enough to ask for compliance or adherence. There is a totally overestimation of the compliance of the patient. So these are data from 2 studies. And so the one study compared the patient information, the information given by the patient, with pill counting, and you see there's a difference of about 50% in the compliance. And on the other side, you see this is such an electronical system for the use of the pill box, and on the other side the clinician rating. And again, with this more objective measurement, you again have a difference of about 50% or more than 50%. So I really would say again, and this should be the taken-home message, you overestimate also in your patients the non-adherence, and you should try to change it by better methods of measuring compliance. So this is a study from the group around Lindenmayer, and they found that even only an 8-week study, and these were experimental studies, these were drug studies, they found that in an 8-week study about 1/3 of the patients were non-adherent at least once. Of course, that means not that they were continuously non-adherent, but at least once is already also measured. There was an expert consensus, and they, in the guideline series, they gave advice what should be done to overcome this problem of non-adherence, especially in patients with serious and persistent mental illness, and they recommended that if possible, clinicians should use more objective measures like pill counts, pharmacy records, and probably, when possible, drug monitoring to really estimate compliance correctly and realistically. And also, validated self-report scale may help to improve an accurate measurement. So these are scales like there are several scales. I will come to this later. Self-report scales that can identify some problems in the motivation for drug treatment, and insofar they can help you to make the doctor alert to understand that this might be a patient with the risk for non-adherence. There are several reasons for non-adherence and drug discontinuation, and some of these reasons give a rational basis for what I will speak later on, the shared decision-making. These should be topics integrated in the shared decision-making or in other ways of, in other psychological means to increase compliance. To start with this very simple list, of course, poor insight into the illness, negative attitude or negative subject response to medication is a problem, previous non-adherence could predict further non-adherence, and so on and so on. I will not go into the details. The list is even longer if we do it in this way. So on the one side, again, there are issues around the patient, so perception of the illness, insight into the illness, but also around the patient. That means family support. What is the position of the family towards medications? I know many mothers who do not like that I treat her son with an antipsychotic, and so on. These kind of influences are very problematic. On the other side, we have to start with something which we cannot change, but which is really problematic. The package insert. Would you take a drug when you see all these negative descriptions in the package insert? Of course, side effects, the primary critical attitude, many people in a society, and these are not the simple people, these are the average middle-class people with good education. They believe that for psychological disorders, and of course for them schizophrenia is a psychological disorders, the best is psychotherapy. That's their, let me say, understanding coming already from the 19th century or even earlier, that for diseases of the soul only psychotherapy can be helpful and not drug treatment. So all these kind of stereotypes are problematic, but go to very simple things, the frequency of drug medication. So whether you give a drug once a day or 3 times a day is important. And of course, the type of the drug, whether it induces a lot of side effects or not, can be problematic. Here is an older study where side effects come out as the most problematic thing in terms of stopping medication. But you see also they don't like medication, or I don't need the medication. These are also very often the reasons for non-adherence. So this is another view, so focusing now on the patient's expectations to drug treatment. And I think it's very important that we understand this, because our view of the illness and the drug treatment is very often not the same as the patient's view. So many of the patients suffering from schizophrenia have not in mind that's most important that we cut all the paranoid ideas. Some say, I can live with my paranoid ideas very well now, having some experience with the illness. I even have some control about this, or don't worry so much anymore about them. But I don't like this and that, and probably I will not take the medication lifelong or for long term, so probably I will experience some of my paranoid ideas, but it's better than to have this continuous medication. So their view is very often otherwise, and when it's here first ranked positive influence on the illness and reduction of symptoms, in some studies you do not find this. In some studies on patient views you find other things. So, of course, the lowest possible side effect rate, quality of life is of greatest importance for the patient. Very often the patients say, if I take this haloperidol, I don't like myself anymore, I have no real emotions anymore, and I look like a zombie or whatever. Of course, he is very right. Haloperidol is a very horrible compound for many patients, and we should really try to avoid compounds which increase a lot of side effects, extrapyramidal side effects. We performed a study on the attitude towards adherence in patients with schizophrenia at discharge of hospital stay. We used a compliance rating scale from KEMP, CRS. There's also another one, MAS, medical adherence rating scale. So these are the most prominent scales in the field. And we found that at the end of the hospital treatments, at discharge, 33% were responding in a way that they have a negative attitude towards treatment with drug. And of course, this is then predictive probably for further non-compliance. And we found that especially non-insight into the illness was closely correlated with the negative attitude to drug treatment. This is another interesting study from Baviera. It's, I think, an Italian. So he used these two compliance rating scales I already mentioned in a huge group of patients, and then he made a factorial analysis, principal compound analysis of all the data together. And he found that the patient view on compliance and the doctor's view on compliance was somewhat different. So again, we have to understand that doctors have other backgrounds and other indicators for compliance than apparently a patient have for compliance. Especially in the recent past, the cognitive impairment in schizophrenia was seen also as a problem related to compliance. So very often we expect too much from our patients when we describe, and let me say, very complicated medications schemes and explain it to them. So you must explain it repetitiously to them and also write it down, because they might fail to understand what you want from them if you don't do it like this. There was a lot of expectations that the second generation antipsychotics might help us in terms of compliance, but the data are unfortunately not as good as it was expected. In some studies there's a difference of 10% between the first and second generation. In some other studies like this one, it's only 4%. So how to improve compliance? There are different ways, of course. And all the reasons I mentioned can be seen also as, let me say, focus aspects where we can try to improve the compliance. So better efficacy profile of the compound, better side effect profile of the compound, more convenient application schedules, as I said. And of course, there are several psychosocial measures where we can help to increase the compliance, and also especially if we include also the environment of the patient, that means the family or caregivers, into these psychosocial activities. I mentioned already that there are some expectations that the second generation antipsychotics are better under the aspect of subjective well-being. Indeed, there were some studies who showed this, but in general, let me say, the signal was not so overwhelming as we expected. But nevertheless, on the other side, if you take the UFES study, this European first episode study, where they compared different second-generation antipsychotics and one first-generation antipsychotic, haloperidol, it came out that the continuation rates were better with the second-generation antipsychotics. Some of them were very good, like, for example, olanzapine, and on the other side, the worst was haloperidol, which you see in red on this chart. Of course, also the poor formulation can help to overcome non-compliance in schizophrenic patients, but you know, there are also some cons, and many patients do not like the depot formulation, but you could use shared decision-making to convince them in a way which they accept that this might be a good way to start. Coming to the psychosocial measures, I would like to mention psychoeducation, which is nowadays, let me say, very prominent. especially in the field of schizophrenia treatment. So many university hospitals and outpatient clinics, but also non-academic hospitals offer in Germany psychoeducation. In Munich we performed this study with a special psychoeducation program, bifocal, that means involving also the close relative. And so you see the relapse rate were reduced in this experimental control group design in patients who had psychoeducation. There's also in UK the compliance therapy versus non-specific counseling approach by Kemp, and also they provided positive results, but I'm not so sure whether this compliance therapy really penetrated the field of caring. So I don't know whether this is really now in the practical life. And there's another one also studied by Kemp, compliance therapy versus non-specific counseling, focus on insight. And you see especially that the compliance therapy increased the insight. Yeah, and then there are other ways, let me say, nowadays in the electronic world, there are patient communication and adherence enhancement projects via mobile phone, text messaging, very simple messaging if medication is taken, how they feel at this day, and you can do this every day. And the patient participated very nicely into this, and they liked this. They felt that they are cared very well in this very intensive daily contact. So they felt, principally they had a positive attitude to this, and but they did not really measure adherence. So this is an open question. So what is shared decision making? Shared decision making. So on the one side you see here the old paternalistic model I started with in my career, and also in my presentation I started mentioning this. And here we have the shared decision making approach. That means the doctor gives the patient all information and informs him about all treatment possibilities. He may recommend one option, but underlining that this is his option, maybe the patient might have another option. And finally, he decides about the treatment together with the patient, taking into account his personal views on, let me say, drug treatment or psychotherapy in general, on an individual drug and an individual psychotherapy, and so on and so on. And the patient has, opposite to the paternalistic model, a very active role. He receives all the information, forms his own opinion, he discusses his preferences with the physician, and he decides about treatment together with the physician. And so it's really a shared decision making. And it was tested in Munich in the group around Hamann and Kiesling, and they, for example, they asked in a pilot study how many doctors are offering this kind of shared decision making, and then they randomly assigned patients to receive shared decision making training on the one side, or cognitive training. This was also a very small group, so these were only feasibility studies. And what I think is quite interesting, so shared decision making yielded higher participation preferences and increased patients' desire to have more responsibility in treatment decisions, which continued to 6 months follow-up. But there was also a but. Patients in the intervention group, in the shared decision group became more skeptical of treatment and were perceived as more difficult by the psychiatrists who were not involved in the study, by the treating psychiatrists. So the psychiatrists were faced with a more demanding patient, asking for more information every day, and not only be tolerant in and compliant in drug intake, so the traditional role of the patient. So there might be also a problem. So in another study, it was found that about 50% of these German psychiatrists offered in clinical condition, hospital condition, that they offer this kind of shared decision making, and they also gave information that of course not all patients are adequate for this, but you need certain patients, let me say, which are a bit more stabilized, especially if we are thinking about schizophrenic patients. And so it was seen as useful for well-informed and compliant patients and for those who currently dislike the antipsychotics, so they needed this information. And on the other side, it was, let me say, more practical and well-received for issues like work therapy, future housing, and psychotherapy, but not so much for drug treatment, because the doctors felt that in drug treatment they are the experts and they don't want to hear all these buts by the patient. So it's an ideal situation which we try to achieve, but the doctors have to change their role. So this is an example how this was done in Munich, this in a shared decision-making project. So they developed, this was in schizophrenia and focusing on drug treatment, and they developed first a booklet with 16 pages. Then this booklet was given to the nurse in charge on the ward and to the patient, and in a first step these two discussed about this, and the nurse gave further information, and later on there was also a face-to-face situation with the doctor, with the psychiatrist, and they continued to discuss about this. They had additional material to be offered, even also charts to be shown to the patient, and based on this the shared decision-making process was done. And in the first study it was also looked whether this program increased the compliance in schizophrenic patient. It was found that there was not a clear-cut difference in the randomized control study, so treatment as usual versus shared decision-making. But if they looked more into the details, they found at least a tendency that patients with the shared decision-making intervention had fewer rehospitalization rates. And on the other side, their knowledge about drug treatment and the necessity of drug treatment to reduce the problems of the illness were well understood in this better understood in this shared decision-making group. So what are topics, for example, in such a program for schizophrenia? These are the topics. So it's a huge field of topics we can discuss with the patient: psychological symptoms, diagnosis, causation of the illness, and so on and so on. So that's a bit also then like psychoeducation, then the selection of psychopharmacotherapy in general, and then special aspects of psychopharmacotherapy, then psychosocial intervention, and so on and so on, and also, of course, then psychotherapeutic issues. I will not go into the details here. Time is over, and so I would only like to mention again, non-compliance is a very, very important issue in terms of suffering for the patient, in terms of negative treatment outcome for the patient, in terms of cost for the healthcare system, and so on and so on. And of course, it's very complex in terms of risk factors, and the most important is that it's mostly overlooked by ourselves. Most of us believe that our own patients are compliant, only the patients from the other doctors are non-compliant, but of course on an average there's 50 to 70% non-compliance on a long-term basis, and long-term basis means only here 6 months to 12 months. So we really have to focus on this. There are several measures to overcome this. A lot of psychosocial intervention, like especially psychoeducation, which is group treatment program mostly. And when we only look into our own field of personal responsibility as a doctor, I think shared decision-making is a way to go into the better direction. And of course, shared decision-making at the end, it is an ideal which we probably will not reach from one day to the other, but we can approach this ideal day by day. So my time is over. Thank you for this signal. Huh?